bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, the Holland Bloorview Children's Rehabilitation Hospital Foundation, the Children's Hospital Foundation of Saskatchewan, and Trillium Health Partners. We would also like to thank the following Keystone and program partners for their ongoing contributions that support all of CAFC's programs and activities. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can also share your thoughts and questions on Twitter by tagging @CAFCTweets and using the hashtag CAFCPresents. All of our webinars are recorded and can be found on the CAFC Knowledge Exchange Network. Use the CAN to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAFC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive.
Hello, everyone, and welcome to today's episode of CAFC Presents. I'm Doug Maynard, the Associate Director at CAFC, the Canadian Association of Paediatric Health Centres. And today we're going to be talking about playtime with our session titled It's Playtime, Unexpected Reasons Why Physical Activity is So Important for Kids. So it's going to be a great topic today, and I'd like to thank the CHEO Research Institute, one of our KT partners that we acknowledged at the beginning, for working with us to help identify great content that's coming out of their research institute from a wide range of topics that they've brought forth. So this is just one of the many great research projects. We've had individuals from this research group within the CHEO Research Institute, the HALO research group, the Healthy Active Living can't remember an obesity research group, but I'm sure our presenter is going to explain to us exactly who that is. So our presenter today, it's my pleasure to introduce Dr. Patricia Longmuir, who's a scientist in the Healthy Active Living and Obesity Research Group, just as I thought, at the CHEO Research Children's Hospital of Eastern Ontario Research Institute here in Ottawa, where she's interested in the promotion of physical activity to children with medical conditions and disabilities, and the use of physical activity to prevent and or treat morbidity. So it's my pleasure to welcome Dr. Patricia Longmuir to the virtual podium. So over to you, Dr. Longmuir.
Thanks very much, Doug, and welcome everybody. We've got a bright, sunny day, warm day here in Ottawa. It feels like summer, so hopefully the rest of you are experiencing some nice weather after the bad weather we've had the last few days. It hasn't been exactly the best for physical activity outside. As Doug mentioned, I'm a scientist here at the CHEO Research Institute in the Healthy Active Living and Obesity Research Group. So our research group is 8 scientists who investigate various aspects of healthy active living and obesity in children and youth, from preconception and pregnancy right through to adulthood. And in addition to the scientists, we have our group is about 35 to 40 individuals altogether, including our staff and our graduate students. We have about 15 to 20 graduate students at any given time. And I am the main scientist in our group who deals almost exclusively in the area of children with medical conditions and disabilities. So on the healthy active living side, not necessarily that have obesity. So I don't focus on obesity, but I focus on the healthy active living part of the HALO acronym among children with medical conditions and disabilities. Traditionally, in pediatric health care, we have thought of exercise primarily in terms of exercise testing. So we measure the amount of energy that children require during different levels of physical activity, or their mechanical efficiency or the perceived exertion during exercise. And this is usually done to inform our care of these patients. How much activity are they able to endure, how much and how efficiently do they burn energy, how efficiently do they move, and that gives us insights into what's happening with their medical condition or whether things are changing, or often can be a warning sign for problems that have not yet been recognized clinically when the child is in the resting state, which is typically the way we see them in a clinical setting. beyond sort of the classic exercise test in the last 10 to 15 years, we've seen a growth in other types of assessment in pediatric settings. So in the center of your screen here is one model of accelerometer that we use. There's a number on the market, but these are small devices about the size of a toonie that children can wear for days at a time, and we can actually measure the amount of movement that they perform continuously for hours and hours or days in a row, which really gives us a good objective measure of their healthy lifestyle or their unhealthy lifestyle, as the case would be. We also have ways of assessing movement skill or health-related fitness, knowledge, motivation. So we've seen in the last couple of decades a growing use of other types of assessment in pediatric healthcare beyond the traditional sort of treadmill exercise test. Now, Dr. Oded Bar-Or, many of you may know that name. He was a researcher at McMaster in Hamilton at the Children's Exercise and Nutrition Center for about 3 decades. Unfortunately, he passed away about 5 years ago now. But he's really considered to be the grandfather of the whole area of pediatric exercise medicine, or how we can use exercise and physical activity to promote health in children with chronic medical conditions and disabilities. And his key phrase that hopefully is a major take-home message from my talk today for you is kids are not mini adults. And as people involved in pediatric healthcare, I know you've heard this before. And just as it applies in many other aspects of our care of these children, it applies to physical activity and exercise as well. So children and youth don't do physical activity in the same way that adults do. Young children don't understand the pacing to go out for a jog, for example, the way an adult would. They don't have the same motivations to participate in physical activity, and their physiological responses to exercise are also different. They're slower and weaker than adults. They perceive exercise as less intense, so they can actually be doing the same amount of work as an adult, but they will consistently say it's not that hard. And they also recover faster from exercise, so there's definitely some advantages on that side of things when you're young. In terms of children with medical conditions and disabilities, there's really 3 types of activity, categories of activity, for want of a better word, to keep in mind. The first one is dynamic activity, and that's shown in the middle of the slide with the bike riders. It's also walking, jogging, swimming, anything that gets your heart rate up and your breathing rate up and uses large muscles is dynamic types of activity. There's also static types of activity, which are things like hanging from the monkey bars, weightlifting we traditionally think of as a static activity. So things that require a large amount of effort typically or often will trigger a Valsalva maneuver and have implications for peripheral resistance and blood pressure response during exercise. And then the third category that I find is often relevant to kids with medical conditions and disabilities are the degree of impact in an activity. So whether there's an expectation of deliberate impacts with equipment or other players or the environment, whether there's a high probability of accidental impacts or whether there's no impacts, and that depending on which medical condition you're talking about, each of these different types of activity may be appropriate or more appropriate or less appropriate. Another concept that's become much more widely known in recent years is the concept of physical literacy, and this actually came out of the adult literature first, with research showing that whether or not you engage in a physically active lifestyle really is not determined by measures of physical fitness alone. And so there's other things that play into your capacity for a physically active lifestyle, as it were. And so the international definition of physical literacy is the motivation, confidence, physical competence, knowledge and understanding to value and take responsibility for engagement in physical activities for life. And a couple of years ago, most of the Canadian organizations that deal with children's physical activity primarily came together and reviewed, because prior to that we all had different definitions of physical literacy, and they came together and developed through a consensus process, agreed to adopt this definition as the Canadian definition. So now whether you go to PHE Canada about physical education in the schools, or participation, or sport for life about organized sport, everyone should be approaching children's physical literacy with this same inclusive definition in mind. Some of the work that I've been doing here at the CHEO Research Institute in conjunction with Dr. Mark Tremblay, in keeping with that definition, or to reflect that definition, is to find a way of actually assessing children's physical literacy. And so we've been working on the Canadian assessment of physical literacy. There are other physical literacy assessments that you can find from other organizations as well. And certainly if you go to our HALO website, and you can find, or to the CAPEL website. CAPEL is the acronym that we use for the Canadian Assessment of Physical Literacy. All of our publications that provide you with all the documentation regarding validity and reliability of the assessment as a whole, and each protocol within the assessment, are all available on the website for you to look into the details. But as you can see, we've structured the assessment around the 4 components of the physical literacy definition. So knowledge and understanding, daily behavior, motivation and confidence, and physical competence. And just to give you some examples, so within the physical competence domain, there are protocols that assess movement skill, aerobic endurance, body composition, and musculoskeletal fitness. And the way the CAPEL is set up is you can do the entire assessment, or you can just choose one protocol, or you can do one domain. So it's designed to be modular, and that way you can choose what's most relevant to the children that you're dealing with and the setting that you have and the space available to assess them. The daily behavior domain includes protocols, daily step counts. You can do those with pedometers, which are much less expensive, but you can also do it with accelerometers if you have that technology available. We get children to self-report their sedentary time and also their moderate to vigorous physical activity, or what's called MVPA, which is the higher intensity, faster than a brisk walk or more effort that is associated with good long-term health outcomes. The knowledge and understanding component is based on the physical education curricula from all provinces and territories in Canada, so the commonalities between those curricula, since education is provincial. So things like the physical activity and screen time guidelines, safety during activity, and terminology in physical activity. And then the motivation and confidence domain looks at predilection, self-adequacy for physical activity, activity compared to peers, benefits and barriers to activity, and leisure time preferences. So I think this is a good time for kind of the first poll of the audience, Doug, if we can set that up. And I mentioned that one of the knowledge components of the CAPEL is that children are expected to know what the physical activity guidelines are. And so let's see what our audience knows about the physical activity guidelines. So first, for the early years, for children 1 to 4 years of age, how much physical activity should children in this age group have each day? 60 minutes a day, 120 minutes, or 180 minutes?
Yeah, so this is your opportunity as the audience to provide your input. Just go up and click your answer on the screen to enter a response, and we'll see what the audience thinks. See how well in tune they are with the physical activity guidelines for the early years age group, 1 to 4, and then we're going to follow this up with the next age category right after this once we see what people think about the early years. So just give everyone another couple seconds before we close this off. All right, so we'll close that, and it looks like, it's almost 30% all the way across. 33% said 60 minutes, 37% said 120 minutes, and 30% said 180 minutes.
Interesting. All right. Okay, and then can we do the same thing for the older children and teens from 5 to 17 years? The options that to choose from are 60 minutes a day of at least moderate physical activity, vigorous physical activity 20 minutes a day, 3 days a week, strengthening activity 4 days a week, or all of the above. It's a little trickier.
Yeah. All right, so we'll share those results. So 66% said all of the above, 27% said at least 60 minutes of moderate exercise a day, and 7% said the 20 minutes 3 days a week of vigorous.
Vigorous activity. Okay. And the flip side of physical activity is actually screen time, sedentary time or screen time guidelines that we have for Canadian children. So 2 more poll questions, one for the early years, 60 minutes a day, 120 minutes a day of screen time or none.
Close this one off, and it looks like 67% have said no screen time, 31% said 60 minutes a day, and 2% said 120 minutes a day.
Okay, and one last poll question for children and teens, screen time guidelines. 60 minutes a day, 120 minutes a day, or none except for homework. And all of these values are, we recognize that children at school have some homework and schoolwork that they are required to spend some mandatory screen time. What we're talking about in the screen time guidelines is the optional or leisure time use of screens in addition to the homework or school requirements.
All right, so we'll close that one off, and it looks like 58% said 60 minutes a day, 40% said 120 minutes per day, and only 2% said no screen time, except for homework.
Awesome. Well, I must say, I really like the fact that people are picking very limited amounts of screen time. That's awesome. You can tell I'm talking to people who are in the healthcare business. So what are the Canadian guidelines at the moment? For the early years, physical activity for infants, the evidence-based recommendation is simply that several times daily they're involved in physical activity. So there's no specific parameters more than that. It's just to make sure that they're moving and involved in physical activity several times a day. But for children from 1 to 4 years of age, the recommendation is a minimum of 180 minutes of physical activity per day. That activity can be of any intensity, so it doesn't have to be vigorous or running 100 miles an hour. But we want them to accumulate 3 hours, a minimum of 3 hours of movement during the day, even if that's a fairly light intensity. For screen time for the early years, the recommendation is always to minimize the sedentary time and particularly long stretches of sedentary time. So you want to break up the sedentary time, so if they are on screens at school or doing homework or whatever, get them up from the screen and moving around even for a few minutes to try and break up this long bouts of sedentary time. For children less than 2 years of age, the recommendation is no screen time at all. The Canadian recommendation for 2 to 4 years is less than 1 hour of screen time a day. Personally, I like screen-free until 3 is usually what I tell families. I know it's really, really attractive in our healthcare settings to occupy the kids in the waiting rooms and the exam rooms with screens. But the more that we can not model that for parents or not encourage parents to resort to screens, especially in young babies, it would be really great as far as the evidence that currently exists in terms of their development. For the older kids, we used to have physical activity and screen time guidelines, but recently we've actually published an integrated 24-hour movement guidelines for that age group. And so that integrates throughout the whole day, getting people to think about physical activity and healthy lifestyles throughout the whole day, not just about their physical activity time or their screen time. And so those guidelines for children from 5 to 17 say that they should sweat for 60 minutes a day. So that's physical activity that's moderate or vigorous intensity that gets their heart rate up, gets their breathing up. Of course, really young children, 5 and 6-year-olds, are not likely to sweat physiologically, but you know what we mean in terms of, higher intensity activity that gets your breathing and your heart rate moving. In addition to that, children should step for several hours each day. So that talks about this lower intensity, light physical activity, but actually moving around and not sitting still for hours at a time. So keeping moving during the day and a lot of schools are actually starting to incorporate movement-based learning into the classrooms. And we'll talk about that a little bit later. For sleep, the recommendation varies by age, but somewhere between 8 and 11 hours a night of sleep is recommended for children and adolescents, and that sitting should be no more than 2 hours a day. So sedentary behavior for voluntary, again, this is sedentary behavior. Obviously, they have to sit in school, but trying, again, to break up any of that sedentary or screen time behavior as much as possible. So there's also, Doug asked me to mention on our website a statement on outdoor active play and risky play, and that's something you might want to take a look at. I don't have any slides about it here, but basically it talks about the issue that we're tending to more and more bubble wrap our children and not give them opportunities to explore and take risks, risks such as, you know, jumping off of a curb or a small level. And so what we're finding is a lot of injuries happen to children because they haven't had the opportunity to develop, to try out risks, to potentially fall and learn sort of what their limits are, so that when they get into a situation where they have to react quickly or they're encountering something unexpected, they don't have the ability to judge and react in the way that they should to keep themselves safe. So that's a little plug. I don't know, Doug, did you want to say anything else about that piece that you were reading?
Oh, I just I saw that statement on your website when I was looking at some of the information about the work that you're doing. It's just at the bottom of the haloresearch.ca website. I put the link in the chat box for people to click on. I just, from my own personal experience with my own children at schools, they really do limit a lot of the outdoor play, especially anything even remotely close to risky. So I thought it was interesting that that Halo had put out this or prepared this position statement on active outdoor play. I thought people might be interested in it, and that there is an opportunity to sign it and sort of lend your support to the position statement as well. So people certainly are encouraged to do that as well if they're interested.
Great. So up until now, you're probably thinking, so what the title of this presentation was Unexpected Reasons for Children's Physical Activity, and so far I haven't heard anything that's unexpected. So let me say that was just kind of a background introduction, and now we're kind of going to move into what I think are some of the less well-known or maybe unexpected information related to childhood physical activity. And so the slide that you see right now talks about the health benefits of physical activity in childhood, and I think overwhelmingly the messaging we hear about physical activity for children is all about their long-term heart health. You know, it'll lead to an active lifestyle in adult, or more likely to lead to an active lifestyle as an adult, and a lifetime of activity decreases your risk for heart disease, diabetes, obesity, depression, anxiety, cancer, and there's the list. And you know, it seems like every day there's new morbidities that get associated with sedentary lifestyles. But what I think is really important for us to keep in mind is that there are significant health benefits to childhood physical activity immediately in childhood, and that's maybe not often recognized. We may recognize it as professionals and service providers, but parents and families often don't, I find, in my discussions with them. They're sort of thinking about that, you know, it's important to keep them healthy and active for the future, but they don't really recognize the immediate impacts and benefits for their child. So the first one, first point there is normal childhood and growth and development is actually dependent on physical activity. Whether you're talking about learning, you know, crawling and movement skills, navigating your environment, and understanding concepts like over, under, and through, or whether you're physically talking about the growth of our long bones, for instance, which require weighting and pressure on them in order to lay down more bone and actually grow. So we see in children with spina bifida and other forms of early childhood spinal paralysis, their legs often are very short relative to the rest of their body if they don't have that weight-bearing movement associated with them, because their long bones just aren't encouraged through that movement to actually create more bone and grow longer. So literally childhood growth and development is tied closely to physical activity, and parents, I think, very seldom recognize the importance of that. There's also a booming research literature in the last 5 to 8 years on academic readiness and academic learning, cognitive development tied to physical activity. So there's a lot of research coming out showing that even short bouts of moderate intensity physical activity can significantly change children's ability to concentrate, their ability to learn in an academic setting, in a classroom setting, behavior benefits, but also, you can see through functional MRIs and different PET scans and things that people are doing these days in their research, you can actually see the functioning of the brain change in response to the same academic lesson, but either with or without physical activity prior to the instruction. There's also obviously benefits around stress reduction. This aspect of physical activity is well known for adults. Everybody, lots of adults will tell you they go out for a run when they need to kind of get some stress relief. But children actually use physical activity in the same way, and that's not necessarily recognized as readily. And peer socialization is, especially for young children, is almost entirely dependent on physical activity and play. And so if you think of young children with their parallel play, there's not a lot of sitting, talking, and chatting that happens between children, but they interact with other children and learn to interact with other children through physical activity. And it's not really until they're quite a bit older children and adolescents, where they will actually start to socialize through the video games and electronic screen options that we have available to them now. But as young children, it's very heavily focused on physical activity for peer socialization. And then, of course, there's the more widely recognized benefits of physical activity, that it improves mood, it increases attention, improves self-confidence, and obviously it's essential for them to build their movement skills and their fitness in order to develop those lifelong physical activity patterns. Another aspect that's maybe unexpected or less well known is that there are health risks associated with sedentary time. And so these in adults, there isn't literature on health risks in children very much. It's mostly adult literature, but extensive sedentary time increases all-cause and cardiovascular disease mortality, obesity, cancer, psychosocial problems, metabolism issues, bone mineral content, et cetera, et cetera. And the last bullet on that slide is probably the key one, is that these health risks of sedentary time are independent of daily physical activity. So even if you meet the daily physical activity recommendations, so even if kids are getting their 60 minutes of moderate to vigorous physical activity a day, or the 180 minutes of physical activity for younger children, if you have extensive periods of sedentary time, you have elevated health risks associated with that sedentary time. And I know you're probably all thinking, oh man, I spend so much time sitting at work. The good thing is if for the clinicians out there, we know that we don't actually spend extended periods of time sitting. You're up and moving, or at least moving between exam rooms and then talking to patients. And the research is actually, in adults, is actually showing that that's all it takes. You only need a break of, a minute or two every 20 minutes to significantly decrease the health risks of sedentary time. But if you have a child who's maybe active all day at school, but then they come home and they sit in front of the computer for hours on end until they go to bed, we expect there are significant long-term health risks associated with that. So, given what we know about physical activity, the question I usually get asked is, well, how are children with medical conditions and disabilities doing? Are they active enough? And are healthy kids active enough, for that matter? So I can promise you that you can find research literature on virtually any childhood pediatric condition related to the physical activity of children with that condition and their exercise capacity. If you look, there's a huge body of literature out there, not necessarily always the highest quality of studies, and the sample sizes tend to be small in most of them, but there is lots of studies, and they all paint basically the same picture. And so this is just one study that I chose to sort of provide an example. On the right-hand side, circled in red, is the percentage of healthy children who achieve the international recommendation of 60 minutes of moderate to vigorous physical activity per day, and which is the percentage of children is what's on the y-axis. And then to the left of that is children who are obese. So about 50% of obese children reach that recommendation of 60 minutes per day. And then you see children with juvenile arthritis and type 1 diabetes are about 40% that reach that recommendation per day. So a lot of people are surprised when they look at this slide and they say, really? My JIA and type 1 diabetes patients are significantly less likely to meet that guideline than patients who are obese. Wow, that surprises me, because I think my patients are really active. It's individual patients maybe, but as a group, generally, children with medical conditions and disabilities are significantly less active than their peers. And the research studies are pretty consistent in showing this same outcome across studies. This is a study that we did with 987 children with medical conditions and disabilities across Ontario. And the difference with this particular study, the previous one used accelerometers to directly measure physical activity. This study that we did was a survey, so the children were self-reporting what activities they did, and from that we were calculating whether they were active, moderate, or sedentary. And keeping in mind that when you ask people to self-report their physical activity, whether it's adults or children, the literature says that they will always over-report how much activity they do, and the magnitude of the over-reporting is between 20 and 80%. So generally, if they tell you they do an hour a day, they probably do half an hour a day, as a general rule of thumb. And so generally when you ask kids whether or not they're active, or adults for that matter, you'll get about 50% of them that will say they're more active than everybody else. You'll get about 30 or 35% that will say that they're average or they're moderately active, and then 10 to 15% will say they're significantly less active. And in this study, a lot of the disability groups did reflect that breakdown, with some notable exceptions. So children with cerebral palsy actually reported overwhelmingly that they were significantly less active than their peers. And if you think they're already overestimating their physical activity, then it's really an issue of concern. Similarly, for kids with arthritis, kidney disease, or vision impairments, they were kind of equally split between active, moderate, and sedentary, which again, given the over-reporting that occurs, would indicate that there are large proportions of children in these populations that are quite sedentary. And as I said, there's lots of research out there in a whole variety of clinical conditions. The ones on the screen are just an example of some of them that are out there. But if you're looking for research in a particular condition and exercise and have trouble finding it, just feel free to let me know if you have trouble finding anything. But just a PubMed or Google search will get you whatever information that you need. The other thing that I think is a bit surprising or unexpected is that, and there's less research in this area, but the research that we have done seems to suggest that kids with medical conditions and disabilities are less active than their healthy peers, even when they have normal exercise tolerance, there's no restriction of their physical activity, they have normal gross motor skills, and they report good function and quality of life. So we're not talking about the kids whose medical conditions significantly restrict their ability to be physically active in some way, or who are extensively deconditioned after surgeries or treatments or other things. Even when you take away all of those sort of things that would make you expect physical activity would be affected. Kids with medical conditions and disabilities still are less active than their peers. And if you consider that the messaging we're getting in the general population that their healthy peers are not active enough for optimal health, then the kids with medical conditions and disabilities are really kind of probably behind the 8 ball. Just thought I'd check in with you, Doug, because I think this is a bit of a break point in the presentation. Are there any questions that we want to address before we move on?
Yeah, we did have one question came in from Sylvia. She put this question in back when sort of you were talking about the recommendations for physical activity and screen time, etc. She was asking how these recommendations relate to the long-term athlete development model. I'm not sure if you're familiar with that model, but she was just wondering how they correlate with that.
Yeah, they do. So just for the other members of the audience, the long-term athlete development model is a model that's used by sport organizations in Canada to basically guide children and adults, for that matter, across the entire lifespan, your involvement in sport. And so it's a model that recognizes that as starts with younger children and how they should be involved in physical activity, and there's actually a high emphasis on physical literacy programming in the early active start, they call it, which is the earliest stage, I believe, and my memory is maybe faulty, but I think it's active start that's first. And then then the recommendation is that children in it's the fundamentals, fun as in F-U-N, capital, dementals. So kind of for the 6 to 9-year-old age group for typically developing children, the emphasis in programming at that age is on acquiring fundamental movement skills and the fundamental running, jumping, throwing, catching activities that children are going to need to participate in sports at an older age. And then it's not actually, the recommendation under that model is not that not until kind of 8 to 10 years of age do children actually start to learn to train, which is the kind of the next stage. So they actually don't start to learn the formal aspects of sport or sport training until they've had a really good base and are at an older age, and then they can, from there you can either go into a stream that leads you through several stages that lead to very high level competition, or you can go into a different stream that leads you towards active for life and programs that as teenagers and adults and older adults enable you to participate in physical activity. So the physical activity guidelines are a little bit different in that they are the recommended amounts of physical activity, but the long-term athlete development plan is very complementary to those guidelines in that with the younger children, it actually emphasizes that they're not involved in organized sport, but they're rather, if you sign them up for soccer, it shouldn't be a very intense, highly competitive soccer practice for 4-year-olds. It should be something that's an active start that teaches them to be fun, to enjoy physical activity and to think it's fun, and to start to build the basic skills that they're going to need not only for soccer in the future, but any other sport that they try to choose, and that children at a young age are introduced to a wide variety of activities, which is very compatible with the guidelines, which don't specify that it has to be sport for 60 minutes a day. It just has to be physical movement for 60 minutes a day. So I think the two are quite complementary that way, and they and in fact they are also supported by research, sport research that shows that organized sport practices and games, so structured, formal sport, for want of a better term, as well as school physical education classes, actually have a very small proportion of physical movement. So if your child is in a phys ed class for an hour or at a soccer practice for an hour, the research would say that they would have less than 10 minutes of physical activity of a moderate to vigorous intensity as part of that practice, typically. And when we think of that initially, people go, oh no, there's no way that's true at my son's soccer practice or in my child's gym class. It just doesn't make sense. But the reason is that those sport practices and physical education classes, the purpose of them is to teach. And so there's a lot of time spent in instruction and watching other people go, and having one child go at a time or a few children try a drill and then another few while others are watching, because it's an instructional strategy. So in actual fact, the physical activity for an hour in a structured sport program, the actual amount of physical activity time for children is much lower than if you just send them outside to play, which is one of the, back to that outdoor statement on outdoor play that Doug was mentioning. It's one of the points that we make in that the best way to actually make sure that your kids have physical activity is just to boot them outside and let them do their own thing without adults interrupting. So hope that answers the question.
Yeah, I'm sure it does. It was a very interesting question. The other question that came in the inactive kids, the list of sort of disorders that are or illnesses that are often inactive. You had hyperactivity and ADHD. I thought that was odd that was included in the list. You would think those children are actually moving more. One would think perhaps, but I'm just curious as to if you had any thoughts of why children that are diagnosed with hyperactivity would be in that inactive group.
Yeah, it is it does seem to be a kind of contradiction, and certainly when you talk to their parents don't think they're inactive. And their teachers definitely don't think they're inactive either. But in a lot of settings, their inactivity actually comes out as fidgety. So it's sort of small, it's constant movement, but small movements, and not the type that actually get your heart rate or your breathing elevated the way you would through large muscle dynamic movement. So it's not that they are probably not sitting still as much as other kids, but just because they're not sitting still doesn't equate to getting the moderate to vigorous physical activity, because often if you talk to the kids themselves, they will tell you that the message that they always get from people is to stop moving and to sit still, and so that they perceive as not having much support from adults and teachers and parents for being physically active.
All right, and I think that's the only questions we have right now, so that's my chance to remind the audience, if you do have any questions, please do type them in as you think of them. Don't feel you need to wait until the end, and when Dr. Longmuir has finished her presentation, we'll get through to the rest of the questions.
Yeah, so there's not too much left, and I know that time is marching on, so I'll just kind of move quickly. As I said, there's lots of research out there. This is, again, just an example of additional things that kids with medical conditions and disabilities might face. So, for example, kids who are treated for pediatric cancer, this was a review paper that looked at the effects of treatment, and you'll see that treatment can cause body fat changes, so obesity, gait and balance abnormalities, and cardiac issues, all of which obviously not only affect the child's capacity for physical activity, but their ability to participate successfully if they choose to participate. So, sometimes we think about the condition or the disability, but don't necessarily think about the impact of the treatment decisions, and this, to me, just reemphasizes for the clinicians that are listening to think about in each stage of the child's treatment, specifically revisiting physical activity recommendations, because I know I often talk to families and they tell me, oh, we're not allowed to do X, Y, and Z. And when I actually go to the physician, they say, no, that's not right. And the reason is that the parents are recalling that, when the child was 4 and the child's now 10, somebody told them X, and they meant it to be temporary. Since then, the children's condition has changed dramatically, and they're not on the same medications, or their disease isn't at the same situation, and the same conditions don't apply. But we are very good at telling them when they can't do things, but we're not so good at telling them, okay, remember somebody told you this before? Well, now because we're on this different medication, that no longer applies to physical activity, and now you can do these kinds of things that you weren't allowed to do before. Some of the things that I hear in research that I've done with parents, they emphasize feeling very uncertain about their child's physical activity with a medical condition and disability, and most clinicians will tell you that they do discuss this with their families, but the parents still talk about, they can tell me exactly the words that they were told by the clinician, but how those impact day-to-day choices of what their child has the opportunity to do at a birthday party or at school. There's still a lot of uncertainty, so that's for parents a big issue. They know that childhood physical activity is important for the children long term, but they don't necessarily recognize the importance of it right then when they're in the midst of treatment for the medical condition or disability. And they talk a lot about the perception of the child as fragile, not necessarily their own perception, but the perception of teachers and daycare workers and parents of peers, when their child goes to a friend's house or whatever, that how to deal with other people's perception of the child as being particularly fragile and not really suitable to enjoy physical activity. I've also had the opportunity to speak to a lot of children about physical activity and ask them what they wish they could do. I wish I wasn't always the slowest is often something that comes out, and I think trying to counsel our patients about activities where they can be successful and they can keep up with their peers is really important for building that self-confidence and motivation for physical activity, and also to convey to them information about any physical activity limitations in a way that they can really understand. The child who said, "I wish I hadn't failed my exercise test," literally thought her body was not capable of exercising because she'd been told she'd failed her exercise test. When I actually talked to the clinician, what they meant was she hadn't really given it much effort, and so they hadn't got her good reading on the exercise test, and it had nothing to do with her capacity. The other thing I would encourage clinicians is to actually talk to children directly, even young children, about their physical activity. We tend to ask them if they play with their peers and if they can participate in gym and if they can keep up with their friends at recess, but not to really talk about the importance of physical activity and why it's important for them, or maybe more important for them than even their friends. And when I ask children, we make Mr. Potato Head doctor dolls, and I ask them to talk to their doctor about physical activity or what their doctor says to them. They talk a lot about talking to their doctor or their doctor talking to their parents, but not talking directly to them about their physical activity. They might ask them what movies they saw or whatever. And I hear the same sort of theme all the time, but the quotes that are on the screen there were taken exclusively from a focus group that I did with kindergarten kids, so kids who are 4 and 5 years of age, who already are recognizing that the doctor talks to their parents, but they don't really talk to them, and or they don't talk to them about physical activity. So even though we tend to think about talking to the parents until the children are kind of teens as a model of care, talking to the kids themselves is really important for them to understand their physical activity. Another phenomenon that we're just starting to investigate, and we don't really have any answers yet, but we hear from a lot of families about kids who've been active at younger ages, and around grade 4 they start to get very apprehensive about physical activity. And that continues to grade 6, and then after grade 6, they either resume their activities or they completely drop out of physical activity. And we're not entirely sure why that happens, but it seems to happen quite commonly across kids with different medical conditions, where they seem to begin to worry about whether or not a physical activity is appropriate, or whether they're going to have to go back to the hospital, or whether they're going to exaggerate their medical condition if they participate in physical activity. I think given timelines, I'll flip through the next couple of slides very quickly, but basically I want to convey the message that part of the reason why parents don't get clear messages, I think, about physical activity is because clinicians don't have clear guidelines in terms of the published research. So when we summarize, this is an example from for cardiac patients for aerobic exercise, but you can see the number of publications and the difference in the recommendations across the x-axis at the bottom. And the one that I like is this one, which is perfectly divided between yes, all for the same specific cardiac condition. 8 publications said yes, you can do any level of competition, including high-level competition. 8 said you can do recreational activities but not competitive sport. And 8 didn't make any mention of whether or not you should be concerned about the level of competition. So perfectly even split. And I think that type of lack of clarity from us as exercise scientists to clinicians is a source of a lot of the uncertainty that parents feel. The good news is that we do have ways of intervening. So we can do home-based physical activity interventions for children. They don't have to come to a fitness class 3 days a week and work out on a treadmill. We can have them do play-based activities with their friends at home, and we can see big changes. So MVPA is moderate to vigorous physical activity. TGMD is a measure of motor skill, strength, and flexibility. So you can see that these measures, after 6 months of a home-based intervention, had increased 50% from baseline. We also saw, interestingly, that children reported that their parents were more encouraging of their physical activity and provided more emotional support for them to be involved in physical activity after this intervention. And then 1 year after the intervention was done, we hadn't talked to them in a year, we went back, we saw some attenuation of the gains that they had made, although they were still 15 to 25% above baseline. But interestingly enough, on the right-hand side here, what we saw 1 year post-intervention was increased self-confidence. And so it looks to us like we can immediately, actually giving them that home-based exercise program will increase their skills and increase their physical activity and get their parents more supportive of them being involved in physical activity. But after that happens for a while, and they are increasing and they are participating more, then eventually we see it's kind of a delayed reaction where we see increased self-confidence for physical activity, which according to the adult literature at least is what really ties you to a lifetime of physical activity, is that internal motivation and self-confidence for physical activity. This is just another example of a review that looked at, in this case, rheumatic disease, but I don't expect you to read all the details, but basically, if you can tell by all of the up arrows, they weren't necessarily changing peak VO2 or VO2 max measures, so maximal exercise capacity through these, but having significant impacts on physical function, health-related quality of life, strength, aerobic fitness, and power, vertical jump, balance, all kinds of daily physical activity. And this is a review across multiple studies. Similarly, there's research that shows in kids with Down syndrome, if you give them an intensive treadmill intervention before they're walking, they'll walk sooner and they'll walk with a longer gait, which is a more mature walking pattern than kids who either don't get an intervention or get a lower intensity and non-physical activity intervention. So physical activity can happen, but children with medical conditions and disabilities need support to make that happen. We need to provide healthcare professionals and families with clear activity guidelines, and it's definitely a complex phenomenon, but so far home-based interventions seem to be effective. A lot of parents talk about how to balance activity and their uncertainty, and that's definitely needs more research on our perspective. We offer here at CHIO physical activity counseling through master's interns that I have working with me, and I'm going to skip through this pretty quickly. We also are working on developing some resources that focus on what children can do instead of what they can't do to convey options to parents that we're hoping to test soon. We have a grant in review at the moment. I think I'm going to skip to the last poll just to get a sense from you in terms of what's available in your physical activity in your own center. Do you have exercise testing available, physical activity information available, or individual physical activity counseling services? And then I guess once we finish that poll question, we have a wish I had. What do you wish you had? So Doug, if you can open those polls and then people can vote.
Yeah, so we got the poll is open. So the question is, what physical activity is available now in your center? And this is a choose all that applies. So you can put a checkbox in any of the three or all of the three if you want. So we have exercise testing, physical activity information, and individual activity counseling. All right, so we'll close that one off. And it looks like most people, 77% say they have physical activity information, 61% have individual activity counseling, and 55% have exercise testing.
Oh, interesting. I didn't expect so many people to have individual counseling available. That's great to hear.
And the next poll is, what do you wish you had? So what physical activity do you wish you had available at your center? Again, the same choices: exercise testing, physical activity information, and individual activity counseling. And almost 70% said they wish they had individual activity counseling. And then 50% said they wish they had exercise testing, and 42% said they wish they had physical activity information.
Awesome. So I think that's the end of the presentation that I had prepared. I know we're only got a couple of minutes left. Are there any other questions? Or?
Yeah, we don't have, I'm sure there may be some people typing some last questions in before we sign off, so we'll give everyone just a few seconds. If there is any questions that are coming in, we'll give you a chance to type them in before we sign off and maybe go a couple seconds over. The one question that did come in was, is there a printable document or a link to the guidelines that you talked about? Specifically, they were looking for that 4 diagram with the sweat, step, sitting, and sleeping segments. Where would they find that information?
Yeah, so I think in the web links that I sent you for the presentation is a link to the Canadian Society for Exercise Physiology, so www.csep.ca. So if you go onto that website and there's a link to physical activity guidelines, and when you click on the guidelines link, you can find all of the guidelines. So that's the integrated 24-hour movement guidelines for children from 5 to 17 years of age. Particularly the one you're interested in is on there, and it's available for free download, PDF format download, or you can order printed copies of that page if you want to have them to give out to your patients. But there's also guidelines for all, there's physical activity guidelines for young children, for adults, for older adults. There's screen time guidelines at different ages, and so there's a whole selection of guidelines on that website.
All right, and Kim did find the link as you were reading out the link, and she did share it with I shared it on her behalf with the audience, so you can just look in the chat box there, and there is you can click right through to it. The next question came in, a few people asking if they will be able to have a copy of this presentation. There is a little handout section of the control panel. You should be able to download it there, and it will be available on the Knowledge Exchange Network along with the recording of this session. But the last question I think we'll take before we sign off is Jennifer's asking, how can community sport providers be supported in understanding that this population can be active?
That's a great question, and it's actually part of one of the slides I kind of blew through due to a lack of time. But so we had done this initial project where we've actually been talking to recreation professionals, to clinicians who care for children with chronic conditions and disabilities, and patients and families, to get their perspectives on healthy active lifestyles and to see actually where the similarities and differences occur. And one of the outcomes from that project we tried as a pilot was actually a webinar for recreation professionals where they could ask questions about kids with different types of disabilities and chronic conditions, what they have to be aware of, and all of the questions that we found, basically trying to deal with their questions and uncertainty, because they often get mixed messages. They'll, they may get information directly from the physician that says the child can do anything, but the parents are saying, no, they're not supposed to do this or that, so they often get conflicting information, or they just are not aware, or they feel like they're not aware if there's particular concerns or safety concerns or issues that they should be aware of in terms of the child's limitations for movement and that type of thing. So, as I said, through this project, we did develop on a pilot level a number of resources, and we actually have a grant in review right now to try and implement that on a wider spread basis. So if you want to get in touch with me, I can sort of tell you in more detail about what we were developing. We're working on it to answer that question, but basically I think the important thing to keep in mind is that I say to people is that the guidelines for physical activity are the guidelines for all children. So if it's 180 minutes a day, it's 180 minutes for young children, it's 180 minutes for all young children. It's 180 minutes of activity within the activities that they're capable of doing. And it's actually only a relatively small, very small proportion of kids with medical conditions and disabilities that would have restrictions that actually impact their participation in community sport and recreation programs at the, quite apart from it's maybe different at the highly competitive, serious level of sport, but certainly at those long-term athlete development stages, active start, fundamentals, and even learning to train, any programs that are sort of targeting those age groups, it's a very, very tiny proportion of kids with medical conditions and disabilities who would have any restriction for participating in those activities. And so usually just asking the parents can provide you with the information that you need. We also have published, and it's available on the CSEP website, the www.csep.ca, same link as the guidelines. If you go under their position statements, they've published one of our position statements on the risks and benefits of physical activity for children. And in that statement is kind of as a recommended question that you ask on registration forms, which is basically you ask the parents, has a healthcare professional told you that there are some types of activity that your child should not do? And basically if you ask that question and you got to know, then the child may have a medical condition or disability, but there's nothing you need to worry about.
All right. Well, thank you very much for that. I think that's some great advice and some great resources. The link to the CSEP site, as well as the Halo Research .ca site. Anywhere else that people can go for more information that you'd like to share before we sign off?
No, I just encourage people generally to go to the general physical activity, Participaction and all those sort of general physical activity promoting websites for children. I think often we think that children with medical conditions and disabilities need something special. Like we developed the CAPL, the Canadian Assessment of Physical Literacy. I can't tell you, probably the most frequent question I get about it is, when are you going to do one for children with disabilities? And it's actually designed so the kids with disabilities can do it as well. There's scoring adaptations in there, so we've used it already for kids with disabilities. The same with the physical activity guidelines. I hear a lot, well, what are the guidelines for children with disabilities or children with medical conditions? And the more that we can keep our minds thinking that these children follow the same guidelines. I do a lot of research with kids with very complex cardiac problems, which you would think would be, that would be a risky population for physical activity, and the guidelines are still 60 minutes a day of physical activity within the types of physical activity that they're capable of performing. So any of the resources that you have in your community that promote physical activity for children are just as suitable for 99% of children with medical conditions and disabilities.
All right, and I think with that, we are a little bit over time, so I think we will wrap it up. So thanks very much for a great presentation and the great resources and everything. It was really a great presentation, and we saw lots of comments and questions from the audience, so I'm sure they would agree with me. So thank you very much for joining us today.
Thank you.
All right. We do our webinars every Wednesday at 11 a.m. Eastern Time, and as you can see, it's great when you can watch live, as those questions and really enrich the discussion. But when you can't watch live, we do make these recordings available after the fact on the Knowledge Exchange Network, along with this copy of the slides and some of the other links and resources that we talked about today. Next week, on March 22nd, we are going to hear about pediatric organ donation after circulatory determination of death, about the development and implementation of Canadian guidelines. We're going to hear from Dr. Matt Weiss, a pediatric intensivist working in Quebec City at the Centre Hospitalier Universitaire de Quebec, and Amber Appleby, the Associate Director of Deceased Donation and Transplantation at Canadian Blood Service. And they're going to help us understand the process that was used to develop these national clinical practice guidelines, as well as talk about key considerations related to implementation, and provide an opportunity for our community to discuss with Canadian experts in the area of pediatric deceased donation. And then following that, the very next day on Thursday, March 23rd, we're going to have our 6th and final episode of our 6-part series, Life with a Preterm Baby, that we have been doing with our colleagues at the Canadian Premature Babies Foundation. This last episode will be titled Starting Solids, What NICU Parents Need to Know, and we'll be talking about feeding, which can be an ongoing source of stress and anxiety for NICU families long past discharge home. We'll be hearing from dietitians who will address common questions that parents have about transitioning to solid foods, what kind of foods to begin with, signs of readiness, etc. So that's going to be an interesting session, and it will be the last of our 6-part series there. So if you watched any of the first episodes, you won't want to miss that one. And once again, I'd like to thank Prolacta Bioscience for helping support that webinar series. So some great stuff coming up in the next few weeks. Thanks again for joining us today. It was a great presentation, and we hope to see you back here next week. Bye, everyone.